Hello everyone and welcome to this monthly case webinar series. My name is CRITOL and I'm the Customer Success Specialist at Collective Minds Radiology. I hope everyone is as excited as I am because today's speaker is Dr. Imran Lasker, who specializes in MSK and general radiology. But before we start, I'm just going to say some quick words about our global community. We at Collective Minds provide a community-driven clinical collaboration, education, and research services to more than 8,000 radiologists and medical imaging healthcare professionals. Having said that, radiologists use our platform to get help on tricky cases and share their knowledge with colleagues worldwide. It is a great opportunity for radiologists and medical imaging professionals to finally be able to connect fully online on a global platform. I'm going to be your host, and if you have any questions or need any help, feel free to use the chat function on Zoom or just email us at support@cmrad.com. But I'm going to stop talking now, and I'm going to leave the floor over to you, Dr. Lasker.
So, hello everyone. Nice to see quite a few people turning up. So that's really, really cool. So basically, my name is Dr. Lasker. I'm a consultant radiologist, and what we're going to be doing is going through some cases. It's not going to be too complicated because we're going to be doing a series of these over the next few months. In the beginning, I'm just going to go through some basic stuff, and as time goes on, I'll kind of bring more challenging things to the forefront, and hopefully get you guys a bit more challenged with some of the things that we can talk about. Also, it's going to be very sort of based on your feedback. So if you say these cases are too difficult, then fair enough, we can go through more simple cases or less difficult cases and then work our way up. Or if you think these are too simple, we just go from next session onwards to be as hard as possible, basically. So I'm just sharing my screen. I just want to make sure that everyone can see my screen. Sadul, can you tell me whether you can see my screen?
Yep. Yeah.
Okay.
Looks good.
What I've done is just uploaded a few cases to the global platform, and you should be able to access these cases as we go along. This should make things slightly easier for you guys in case you don't have a great connection, which can happen for some people, and they won't be able to see the images as well as they'd like to. So you can kind of work through it at the same time. You don't have to do that if you don't want to. You can just look at my screen. Hopefully you can see what's going on. So, like I said, basic stuff in the beginning. If you do have any questions, please throw it in the chat function, and I'm more than happy to try and answer people's questions as we go along. And like I say, I try to make it as interactive as possible. It's really great when people kind of give their thoughts and to see what they think is going on. But otherwise, yeah, feel free to just, I guess, enjoy the ride if you're into that kind of thing. Right, so the first case is a pediatric patient that has got this unfortunate situation of having fallen over. I don't know if you guys have got kids, but yeah, my kids are always falling over, and when they fall over, I'm always stressed out they could end up having a more significant injury. But then being a radiologist, there's only so much I can really say without having an X-ray to hand. So I guess that's part of the fun of being a radiologist. So when we're looking at this X-ray, I mean, we've got two views. We've got the sort of more AP and we've got a more lateral view sitting there, but you can already hopefully see quite a lot. And as we go through, I'm going to try and explain some key anatomy to be able to sort of get you to understand what is really happening and how to pick up. If you can pick up these, you hopefully be able to use these tools and ideas to pick up more bigger fractures later on. Right, so pediatric X-rays can be a little bit difficult from the beginning, right? You've got growth plates, okay? So that's one thing to worry about, right? Growth plates can be a bit misleading, especially if you don't have very much in the way of experience when it comes to growth plates. But growth plates have a very, very specific look to them. And so if we kind of zoom into here, you may be forgiven to think that this over here is a growth plate. So I'm just going to get the pen, which is a really cool new function from Collective Minds. So you can kind of draw like this and draw like this. You think that could be a growth plate. Yeah, it could be. But when you look at growth plates, it should really get more corticated as you get closer to the edge of a growth plate. And what I mean by more corticated is that as you can see, if you come to the edge of the bone, you can see the sort of how the bone gets slightly thicker. And that should happen as you get closer and closer to a growth plate. Also, you should have the same situation when you get closer and closer to a blood vessel. So you've got blood vessels that go inside the bones and that kind of thing as well already. And sometimes you can see them on the X-rays. And you kind of think to yourself, is this a fracture? Is this not a fracture? How can I tell? And the way to do it is to basically look for increased cortication as you get closer and closer. Because if something's been around the body for a long, long time, the body's had time to kind of accommodate it and put down its foundations so that it's actually a normal structure rather than an abnormal structure. But when you get abnormal structure, and what I mean by abnormal structure is a fracture that's been introduced out of the blue. That's never been there before. The body hasn't had time to sclerose, try and heal. Nothing has happened. And so you end up having a very different appearance from an acute injury when you've got compared to something that's been there for someone's lifetime. So when we're looking at this particular X-ray, when you're looking at an adult patient, one of the big things you want to look for is the radial head. But this is quite a young patient, and you may be able to say that there's no radial head ossification just yet. The whole CRITOL thing is something that we can talk about. CRITOL, for those of you that don't know, is CRITOL. So first of all, the first thing to really come about is going to be the capitellum, then it's going to be the radial head, then you've got the internal epicondyle, then you've got your trochlea, which is sort of way back over here. But the point is, generally speaking, it's good to know the order, but it's very good to know the order. But there are other things that can help us try and identify what is going on in this particular X-ray. So as you kind of come closer to this one, you can hopefully see that there is this sort of radial lucency that is sitting over here. And you think, oh, is that a growth plate? Is that not a growth plate? You zoom in a bit, and you don't see much in the way of cortication as you get closer and closer to those edges. It kind of sort of merges into one, ill-defined, as one would say, kind of very, very ill-defined, and it doesn't continue all the way through from what you can see. So this is going to start ringing a few alarm bells straight away. So the sagittal and the lateral view is kind of what's going to give it to you. And for those of you that can't see it, don't worry, I'm going to work my way through it. So you've got something called the posterior fat pad. And when you've got a young patient, it can be quite difficult to see the posterior fat pad. But here, if I zoom in a bit, oh, hang on, let's get rid of that and go to zoom. And I might have to window a little bit because I know some of you guys have got varying screen possibilities, but you can start to see that there is a kind of almost hypodense area that is kind of pushing outwards from the elbow joint and pushing outwards like so. And that is known as a posterior fat pad. A bit more difficult to see in pediatric patients, I give you that, but as you kind of get better and better at looking at these X-ray scans, X-rays, you'll be able to see that kind of thing a lot better and appreciate that there is what looks like a joint effusion. But don't worry, if you can't see that, no problem. Sorry about that. I think someone's at the door. But the other way to do things is to use something called a champagne glass sign. So I'm going to draw the champagne glass like so. And you can see that, right? It looks like a bit of champagne glass. You're having a nice little cocktail or whatever it is. And if the champagne glass is broken at its neck, then you're probably looking at a supracondylar fracture. So in this particular situation, if you drew a line all the way down like so, and then kind of come in this way, you can see that there is what looks like a radiolucent line with no sclerotic borders sitting at the anterior edge of the cortex of the humerus. And that was more like, that's going to be in keeping with a fracture. It doesn't have that normal sclerotic appearance of a normal structure. On top of that, it does look like there is a break of that champagne glass, which would be this thing over here. And also what you might notice is that it's slightly angulated. It should really be a straight champagne glass, not an angulated champagne glass like this. So all these things together makes you realize that this is going to be a fracture, and something very, very important not to miss. And believe me, although this is a slightly easier case than others, I've seen these things get missed. And the other thing I'd like to say for anyone out there is, even if you don't see the fracture, if the champagne glass looks normal and everything looks aligned, but you still have a posterior fat pad that's raised or a big joint effusion in the context of trauma, you still need to raise the possibility of a supracondylar fracture, even if you don't see the fracture itself. Right, so as far as I can tell, there's no questions coming in just yet. So we're going to go to the next case. So I haven't done these in any particular order because I find that when we're teaching our registrars anyway, you're trying to get through a reporting pack, right? And it's quite good to be able to sort of go through sort of almost random cases. And this is what I want to do. So bring really cool cases forward, and then hopefully through the community, we may have some more cases offered for us to look at during these live sessions at once a month. And we can sort of hopefully learn together and kind of really build a bit of a community thinking with one another. So now we're looking at this particular mandible view. And so a bit of a word to the wise, I've actually seen a situation where you've had an OPG, which is what this is, and people have missed that there's actually an odontoid peg fracture. So be quite careful and just understand that there's more anatomy that is available on an OPG than just the mandible itself. And you can see now that I've pointed out to you, you can actually see that there is an odontoid peg sitting right over here. And you might be thinking, well, why have they got two odontoid pegs? They don't. It's the way they've taken the X-ray that makes it look like there's two, but we're kind of seeing it from both sides. And I seriously have seen a fracture go through like this on an X-ray in the past. But because we're kind of going through some more easier stuff to begin with before we start going for such advanced things, we're going to just have a look at the mandible, right? And some of you may have spotted it straight away, but a few things to be aware of with the mandible is that you've got a bit of anatomy here to be aware of, right? So you've got sort of the body of the mandible, you've got your angle of the mandible, you've got your ramus, and then you've got your, they call it the head, and then you've got your coronoid process as well. And so these are kind of areas that you can get fractures. And actually about 10% of the time you get a fracture over here. And then 70% of the time you can get fractures over here, and less likely you're going to get fractures in these areas over here. So it's really the angle of the mandible that's going to give you the most bang for your buck when you're looking for fractures. The thing to remember about mandibles is that they're like a polar ring, like a big circle. So if you get a fracture on one side, you're more than likely going to have a fracture somewhere else. So very, very important to look for two fractures instead of one. I'm not saying you always get two fractures. It's just very important to be aware of that there could be two fractures. Now, something that people don't often talk about is the teeth themselves. So what I generally do is draw sort of a line down the middle, and then you just have to count like 1, 2, 3, 4, 5, and there's like a missing tooth here, and then you've got your molars all the way, and you should have about 8 going across and 8 going across that way. And if you wanted to talk about a specific tooth, then you'd just use this number system, but go like, okay, so this is going to be the right side, this is the lower jaw, and then you're going to be talking about a third. So you'd be like right lower third tooth. If you're going to talk about the left lower third tooth, you go left LL3, so left lower third tooth, you go 1, 2, 3. So that's how you identify which tooth that you're talking about. Why is it appropriate in this particular study? It's because when you look around each of these teeth, you can see, yeah, fine, there's a bit of radiolucity, but not all that much. And when someone, I guess, has got bad hygiene, well, I wouldn't say bad hygiene, but maybe they're not looking after their teeth as well as they could. Sometimes you can get a bit of a radiolucent line that goes all the way around, and that's known as dental caries. But in this particular situation, the teeth look actually pretty well, although you do have a few missing teeth. You've got fewer than the left lower 8 there. But on this particular side, you can see a bit of a radiolucency, and you think, okay, it could be dental caries, that could be a possibility. But as you kind of go all the way through, you can start to notice that this radiolucity goes all the way down to the edge. Now, this could be a normal structure, maybe, but in the context of trauma, unlikely. And also the fact that there's no evidence of any sclerosis as you come up to the edge of this particular radiolucency raises a possibility, or may increase the likeliness of this being a traumatic injury. Now, you can see here, look, if you come up to the edge over here, it's slightly more radiopaque, or slightly more sclerotic. Edge over here looks more sclerotic, but these edges definitely do not look sclerotic at all. So therefore, this is more likely to be a fracture of the mandible. So now we found one fracture of the mandible. Very, very important we have a look at everywhere else. And the way to do that is to really genuinely take your time and go through it. Like really look closely, draw all the way around, all the way around, all the way around, all the way around, all the way around. All the way around, just to make sure there's no other fractures anywhere else. And in this particular situation, this particular X-ray, you don't have the normal two fractures in two different places. You've got one fracture that extends all the way through to the root and around the root of the, that I guess that's 1, 2, 3, 4, fourth tooth on the left lower mandible. Right. So again, hopefully some basic concepts being thrown in as we go through things. And that's kind of how I want to do these things. So like we'll be able to just bring in loads of different cases, interesting things as we go through. Right. So this patient, a little bit more subtle. If you can see the abnormality, please throw it out there, because occasionally you do get someone who's a bit of a whiz and they throw it and you think, wow, that's pretty cool. So if someone can see it, go for it. Just be brave, put it in the chat, and it'd be really nice if you could do that. But anyway, when we are looking at this is a lumbar spine, right? And so the main thing to do is to try and see what the vertebral and intervertebral heights look like and make sure that they are maintained throughout the image length of the lumbar sacral spine. So that's one thing to do. And the other thing to do is once you've kind of told yourself, okay, the vertebral heights look okay, the intervertebral heights look okay as well. You want to see the alignment, and the way to do the alignment is literally just to draw a line going along the posterior aspect and the anterior aspect. Sorry, I've done a terrible drawing, but you can see that everything's actually kind of aligned, right? So this patient actually, from what I remember, they were walking down the stairs, which I always tell people, do not be on your phone when you're walking down the stairs because you may slip. And this is exactly what happened. This person was walking down the stairs, they slipped and went all the way down, and they had a pretty big impact at the bottom of the stairs. And since that, I've been coming in with back pain. So when you've got someone with back pain like this, you've got to be a little bit more careful and have a really good look around. So let's kind of work our way from the bottom here and get the pen function out. And so what you want to do is essentially draw square vertebra like that. And that looks okay, doesn't it? It doesn't look like there's anything abnormal there. And what we're going to do, we're kind of going to do the same thing as we go along. Next vertebra, yeah, you do have a little bit of lipping over here, and you can get that. You can get osteophytosis emerging from the anterior aspect of the vertebra, and that can be completely normal. Some of you may have spotted that there's radiolucency over here. You think, okay, you know what, we've been talking about fractures all this time. Could this be a fracture? It may be a fracture, may not be, but hang on, hold your horses. Yeah, okay, fine. There's no sclerosis as you come to the edge of this radiolucency, but have you noticed how the radiolucency goes beyond the cortex? And oh, there is a question. So I have seen your question. I'm going to come back to that. When you diagnose EC silent. Okay, so I will come back to that question. Thank you very much. So what you do is then kind of go forward, and you can see that this radiolucency goes beyond the cortex of the vertebra, and therefore this can't be a fracture because the radiolucency shouldn't go beyond. And what therefore you have to remember is that you've got a lot of overlying bowel gas, and you can see overlying bowel gas over here. Again, on the next bit, you can see that there is some osteophytosis emerging from the anterior superior corners and the anterior inferior corners of the vertebra as you go along. Now, one thing I want you guys to pay special attention to is the cortices of the superior and inferior vertebra as we go along. As we come further and further upwards, this area over here starts to look a little bit less well-defined. You see that definition there? This one doesn't look well-defined, and if I get that pen function out, like so, you can start to feel as though this doesn't look quite right. This doesn't look normal at all. And this patient actually did end up going further and finding out that they did have a fracture in this particular area over here, which was kind of seen on the X-ray anyway. Now, I know not everyone uses X-rays, and I'm going to come to your question now. Someone has asked, how often do you diagnose, I guess, fractures on C-spine and L-spine images on X-ray? So the thing is, you have to take everything into consideration, right? Sometimes X-rays are just genuinely a way of just doing a quick look, a cursory look, just to make sure there's nothing big going on. But then when you've got a traumatic injury like this, it is important to remember the next few rules I'm going to say. So when someone's got traumatic injury, the way the human body is, if you're going to fall, and if you're going to fall, generally speaking, you're going to have an T12 L1 vertebral fracture. That's more likely than anywhere else, right? It's just the way the human body folds in on itself or where the impact seems to go. I've always seen it be about T12 L1 L2, that sort of upper lumbar, lower thoracic spine vertebra. So if you did nothing else when you had an X-ray, but only look at sort of L1, L2, T12, L1, L2, then more likely than not, you're going to pick up fractures. It's more likely than not. So when you've kind of got that sort of thing in your mind, you pay a little bit more attention to this particular vertebra over here. So if we count 5, 4, 3, 2, 1, 12. So T12, so T12, L1, L2 is usually where the body will fold. Got to be careful. If there's anything slightly abnormal, I've got to maybe think about doing further imaging. And you can see that cortex doesn't look quite right there. It looks a bit irregular at the top there. So do we routinely go onto CT scan? Again, very, very much based on the clinical symptoms and the mechanism of injury. Because as you know, or may not know, if you work at a trauma center, most people are going to get a CT scan or an MRI scan, right, with any trauma. And this could be trauma just falling from the chair that I'm at right now, or it could just be from some significant trauma. There's a wide gamut of reasons. But the fact is, as long as we're still doing X-ray imaging and expect X-ray imaging to be interpreted by us, i.e. radiologists or radiographers, then it is important to try and understand that there is the possibility of, it is important to try and identify the problems that can occur in these specific areas. So just take a closer look in that area. Okay, so that is the abnormality. So the things I really wanted to show you is how to identify possible end plate injuries, and it can be as subtle as sort of just a discontinuity of the vertebral cortexes, as you see, and everything else can look normal. In the context of trauma, if the patient still has pain, you're probably going to end up doing a CT scan anyway. Right. So unfortunately or fortunately, we see a fair bit of this, especially, yeah, I mean, I see a fair bit of these situations where someone has punched a wall. I become of the thinking that I'm not sure people are punching the wall. Maybe they're punching each other and they don't want to tell people. But anyway, it says on the request form they punched the wall, right? And so the thing is, when you get someone, and not that I'm particularly well trained, I have done some martial arts in the past, but when you're punching someone, and I'm not saying this is what you should do, you don't really want to be punching with your little finger or your false finger. You kind of want to be in the first, the second, and the third metacarpal areas, right? Because actually the distribution of forces is far better distributed through these areas, all the way through to the radius, right? If you kind of go down this area, first of all, you've got a bit of an angulation to go through where the forces will actually go the other way, and you don't have much force to go along the ulnar either. So if you're going to punch someone, you know, you're going to be punching someone with these 2 to 3 knuckles over here, not with these ones. Unfortunately, you get people who, for whatever reason, have punched something or someone haven't done it quite, I don't want to say the correct way. I don't know. In a way that would result in less detriment to themselves, I suppose. And so what you end up getting is like these fractures around the base of the 5th or the 4th or the necks of the 5th and the 4th. So if you looked at nothing else on an X-ray, then I would highly recommend that you look at these areas, only the high yield areas when you've got people who punched walls or punched anything. So when you zoom into this particular area over here, again, you can see a radiolucent line that is sitting within the region of the neck of that 5th metacarpal. So again, fracture vessel, how do we know? So you can see over here maybe that there's this radiolucency just over here. But if you kind of zoom in closer, which is what I'll do for you guys now, there's very obvious sclerosis as you come up closer and closer. That could be normal trabeculation, it could be a vessel, but it's not going to be a fracture. But when you come up to this radiolucency over here, which is what I'll do is just zoom in again. So zoom. You can see there's not much in the way of sclerosis as you come closer and closer to that radiolucent edge. You can see a bit of a discrepancy, and you can also see the discrepancy going all the way across like so and all the way across like so. So this is going to be a fracture, a very, very common place to get a fracture. One of the important things to try and mention, if you can, is there any articular surface involvement? And in this particular situation, we don't have much in the way of articular surface involvement, but it does extend all the way across that sort of, it's actually more distal from the metacarpal neck. Metacarpal neck will be there, and this kind of goes more and more distally and medially as you go further forward, but doesn't quite get to the articular surface. So take-home points of this particular one is if you look at nothing else on X-ray of the hand, make sure you look at the 4th and 5th metacarpals, the necks and the bases. Just make sure you've had a look. And even there's a bit of overlap in this region here. I have seen fractures where you've actually missed, and I will bring that in the next few talks that we have, where you do actually have a very subtle fracture over here because the overlap of the 5th and 4th metacarpals, it did go missed. So it's very worth knowing high yield areas. And because you know the high yield areas, take a closer look at those high yield areas and have a look and see whether there is a fracture there at all. Okay, so this one is someone who has tripped up, and so you've got to go for your high yield areas again. So when you're looking at a foot X-ray and you've got someone that is complaining of pain, the high yield areas is going to be the base of 5th. Oops. Pencil. So it's going to be the base of 5th. That's going to be the high yield areas. Even if you don't have a dedicated view of the foot and you've got a view of the ankle, it's still worth looking at the base of 5th because so often that kind of fracture can get missed. So this particular base of 5th looks okay, and you can get different kinds of fractures where there's articular surface involvement or no articular surface involvement, which is a talk for another day. But that is one area that you want to be looking at in the context of trauma. Now, obviously, in the context of trauma, anything can get injured. But the high likeliness areas are going to be the metatarsal necks. They can get fractured as well. And the best thing to do is to really zoom in and just draw around, like genuinely just draw around. That's what I used to do, just zoom in and draw around every single one and make sure there's no fracture anywhere. Next thing to do is to have a look at the metatarsal heads, because sometimes what can happen is that you can get some kind of avascular necrosis, I guess, of the metatarsal heads, basically flattening of the metatarsal heads. And that is known as Freiberg's infraction. I think they used to say, or they say it happens as a marching injury. People who march a lot, I don't know why, but they would have increased pressure in these particular areas over here, and they can end up getting sort of flattening avascular necrosis of those areas. That's not the case here. We don't have that. So we're still kind of looking around. No one said anything just yet to say they found the fracture, which is fair enough. Don't worry. We're looking at the phalanges. They all look okay. And yep, you do get a bit of an overlap of the terminal phalanges with the proximal. But now when you come up to the big toe, you can see that there is a radiolucent line that is sitting around the tip of the great toe terminal phalanx. Is this a vessel? No, it can't be a vessel because there's not much sclerosis as you get to the edge. And sometimes people have got confused with this one because they think, okay, you can actually see the nail, right? How do I know that's not overlap of the nail? But just draw out the nail, right? You can actually draw out the nail. As you look closer and closer, you can draw out the nail bed, and this does not conform to the nail bed at all. No nail looks like that. So therefore, this is a fracture of the big toe terminal phalanx, and something that gets missed. So very, very important that yes, you do have high yield areas. That's kind of your quick look for fracture, no fracture, but then you've got to go do the hard work and really go through every single view and every single bone as well to make sure there's no fracture there. Right. No questions so far. Good. So this one is an adult patient, and this is kind of in context of what we were talking about earlier with the pediatric patient. Pediatric patients, generally speaking, you get supracondylar fractures, but with adult patients, I would highly recommend you go for that radial head. High yield area, radial head is most likely where people get fractures. It may be because when you fall onto your hand, a lot of the pressure may go through the radius, and as the forces of the fall goes through the radius, the radius gets smaller and smaller as you go along, and then it doesn't have quite the weight distribution it could do, and then it ends up hitting the radial head. So when you zoom in to this radial head, you can actually draw around quite nicely the rest of the cortex, but then there's a sort of, another cortex that pops up there, a bit of overlap, and you kind of draw around like so, and then you can see the sort of step deformity that is sitting over here. Yeah, so yes, exactly right. So someone has said it correctly. So you can actually have what looks like a fracture through that radial neck. But the thing where you have to realize, we're talking about joint effusion. Sometimes you get radial neck fractures that are not going to give you much of a joint effusion because they end up being extracapsular, because you actually get a joint capsule which goes around like so. So if you get a fracture that's a little bit more distal, you won't get much of a joint effusion. But if you go a bit more proximal, you get a joint effusion. So all that stuff about raised posterior fat pad and all that kind of thing will most likely happen in this particular situation, but because this is an intra-articular fracture, but a bit further distally, you may not get that. So very, very important you have a look at the radial neck all the way along and actually have a look at that radial head as well to make sure there's no fractures there. In this particular situation, there is definitely a fracture. Quite important still to have a look at the rest of the bones to make sure there's no other fractures anywhere else. I don't have the lateral view, but in the context of trauma, it is quite important to try and see where there's a coronoid process fracture as well, because when you get coronoid process fractures, it results in long-term instability of the elbow. And again, I will talk about that and go through more intricacies of elbow fractures as we go through the next few months of doing these teaching sessions. Right. Okay, so this is quite important to be aware of. Hopefully that's answered your question. So this is a pediatric shoulder, right? And again, you're worried, okay, so there's a lot of growth plates here. How do I know what's fracture? How do I know what's not fracture? So you do get growth plates around the neck of the humerus. And again, it's very, very sclerotic as you approach the humerus as well, this growth plate as well. But then people sometimes get worried because, okay, hang on, that's not aligned. That's not aligned. There must be some sort of step deformity here because that goes around like so. How do I know what's going on? How do I figure this out? And the best way I would say is to make sure that you draw a really bad outline of the humeral head. And when I say that is, you can be really accurate and draw that line like so and go around like so, but that's not the way to do it because you have to understand that there's going to be non-radiopaque structure that is sitting within the region of the humeral head. And that's going to be sort of this cartilagey stuff that's sitting there, which you won't see on X-ray. And it's actually going to come out slightly further like so. So the way to try and identify whether someone has got any sort of slip or anything like that is to first of all draw a very bad outline. So I've done a worse outline than I anticipated. So you want to draw a bad outline like so, like you kind of come out a little bit like that, kind of extrapolate a little bit, And then you can actually see it's not going to be likely to be an injury within that region. Also, you might be able to see that there is this radial lucidity that's going down like so and down like so. So someone might be like, oh, that's one of the Salter-Harris type fractures. But again, like it's very, very well sclerotic around this region. And also you have to understand that these ossification centers don't ossify uniformly. They don't go outside like this and they ossify and ossify and ossify and ossify. Sometimes you get these stippled sort of areas of calcification. You get sort of areas that calcify, then coalesce, and then eventually become the humeral head that we all know so well. So the other thing is to do when you've got the young peds injuries is to make sure that you can draw along the cortices. You're not necessarily looking for fractures as in cortical abnormalities. Sometimes you're just looking for a buckle, like a bit of a fold within the cortex, which will tell you that this patient has got a sort of buckle injury rather than a full fracture, because pediatric bones are quite soft, quite malleable, and instead of fracturing, what can actually happen is that you can get a bending and a folding of the cortex, which can result in an injury. So some of you may have seen it, don't worry if you haven't, but this patient doesn't have any humeral injury. The humeral head articulates nicely with the glenoid. And again, I'm going to talk a lot about shoulder dislocation stuff as we go through the series of talks that we're going to do over the next few months. But in this particular situation, we don't have much in the way of any evidence of any dislocation. So in this one, what we can see, however, is that the clavicle, which is over here, has got a radiolucent line that goes right down the middle. And you can see that it doesn't quite align the way it normally should. Some of you may be worried about AC dislocations, and that can be very, very difficult in these young patients because they haven't had quite the full ossification of the lateral acromion. And also when you're at an angle, sometimes it doesn't quite angle up right, and it doesn't look quite, you've got to have dedicated views of the acromioclavicular joint to be 100% sure that there is an acromioclavicular joint injury there. But over here, you can see that there is this radiolucency over here. So what we do when we talk about clavicular injuries is that we split it into threes, right? There's going to be inner third, middle third, outer third. So generally speaking, traumatic injuries are going to happen in the middle third, very, very common. You need a lot of force to be able to fracture the medial third. It's going to be car crash injuries, things like that. Lateral third can happen, but generally speaking, you're going to have repetitive stress injuries that happen there. You can have destructive bone processes that happen there. Remember, this is a synovial joint as well. So rheumatoid arthritis, inflammatory arthroses, they can all cause destruction of the lateral acromion. This is a very, very common injury and it can happen a lot. Now, remember, when you're dealing with pediatric patients, you'll be super, super, uber careful because you never know, right? There could be NAI, there could be something else. Now, this is a common injury. That on its own is not going to be enough of a thing to warrant a NAI investigation, which is non-accidental injury. But what you need to do is also have a look at the ribs. It's almost negligent not to look at the ribs as well to make sure there's no fractures there. Because yeah, fair enough, this patient may have fallen over, they may have got a fracture there. But if you have multiple old rib fractures and you missed it because you're concentrating on the clavicle and the humerus, I mean, it could be detrimental to the patient in the long term. So very, very important that you have a look at everything else as well, beyond the humerus, the glenohumeral joint, the clavicle, the acromioclavicular joint, et cetera, et cetera. Okay. Right. So now when we go on to this particular X-ray, I've seen this one come up a lot, where everyone umming and ahhing, and fair enough, you're probably going to end up going to get a CT scan because you're not entirely sure what's going on. But this patient fell on their right side, as now having difficulty moving, and they're saying it's shortened, et cetera, et cetera. So what the trick really is, so what I found a lot of the time is that people will do all the right things by drawing around the pelvic brim, make sure that's all kind of nicely aligned, draw around the femoral heads. But what you really also should do is draw around the lateral femoral neck, the internal, kind of more medial femoral neck, the greater trochanter as well. Once you've done all the drawing, the next thing to do is to take a really big zoom in. Yeah, well done, you picked it up, I can see that. And have another look at the trabeculation. And you can see that this kind of all diagonal like this, right? And that's normal. If you have a discrepancy in that diagonalness, if that's a word, then you're probably looking at a fracture. The other thing that I've seen people not realize sometimes is that there is this cortex, right? Sometimes you get lesions that cause a bit of scalloping of the cortex as well. So very, very important to pay attention to the texture of the bone and also the trabeculation of the bone. And like someone has spotted very well, is that there's more than likely going to be a fracture of the right neck of femur. Because if you look at the other one, there's nice trabeculations, that diagonal line going across one another. But here, on this particular occasion, you can see that there is an increased sclerotic appearance to this area over here. Yes, you do have some normal trabeculation, but it all seems to kind of culminate to this area over here. And even more importantly, as you come up to this area, you can see that there is a bit of a step deformity there. And this whole area doesn't look quite right, especially when compared to the other side. So what you actually have here is not only a neck of femur fracture on the right side, it's an impacted neck of femur fracture on the right side, which, believe it or not, does get missed. And I will show you, I've got some really great cases of bone lesions, et cetera, that will kind of help us understand the whole thing. I'm talking about the trabeculation, the bone density, and the bone texture as well as time goes on. You may spot that this person probably a bit of a repeat offender because there is this increased appearance of cortication within this region. And that may be secondary to a previous fracture that has since healed. So something to be aware of. This patient's probably had a few unfortunate incidences of falling over. Right, so I think maybe this could be, again, it depends on what stage you're at in your training and learning. This may be a bit of a challenge for some of you. So if you can see the abnormality, do feel free to throw what you think it is. I will be impressed. So chest x-rays, there's a whole nuance of chest x-rays, right? There's, we actually run entire courses, whole days dedicated on looking at the chest x-ray because there's so much anatomy involved with chest x-rays. But for the context of trauma, there's only so many things you're looking for. You're looking for a pneumothorax. Yeah, well done. So yeah, exactly, well done. So you're looking for a pneumothorax, and you're looking for rib fractures, dislocations of the shoulder, fracture of the shoulder, clavicles. Genuinely, I had one case where bilateral, so I think this is, so someone was walking along and they fell down a manhole and they didn't fall right in because obviously tried to stop themselves and both shoulders got dislocated. So when they went into x-ray, I think they were a bit inebriated. They were drunk, unfortunately. And so they couldn't really tell you like where the pain was. So when they did the x-rays, because the humeral heads looked symmetrical, no one picked up on the fact that had bilateral dislocated shoulders. Quite unfortunate. So it is quite important to make sure that you are aware that there's more anatomy than just the lungs. But in this particular situation, you are looking for any rib fractures. The way to do that is you obviously look at the posterior ribs first, make sure there's no evidence of any fractures there. But then you've got your anterior ribs that go like so. You just want to make sure there's no obvious fractures there. Anterior ribs can be a little bit more difficult to appreciate. Lateral ribs as well, you want to make sure there's no fractures over there. And I've seen people do this, which I've actually used on the occasion where you put the x-ray sideways and try and see if there's any cortical abnormalities located within the lateral aspect of the ribs to try and identify where there's a fracture there. But quite rightly, a few people have mentioned and quite rightly said, there is some air located over here. So if you're ever unsure about the density of something, the way to try and identify what the density is of anything really is to think about what you know and compare it to something that you don't know. So for example, within the lungs, you know that there is air. So what else within this x-ray has got air? It's going to be everything outside the body. That's going to have air. So if you've got something of this density or something of this density sitting somewhere that it shouldn't be, it's more likely to be air. Anything of soft tissue density is going to look like this stuff over here. The axillary fold has got, your fat, your skin, etc., etc. Anything of bone density is going to look like this. If you see anything like this density sitting anywhere else, you're probably looking at calcifications in somewhere that there shouldn't be. But in this situation, what we can see is a diaphragm over there, and then below the hemidiaphragm, there is this radiolucent line that is sitting over here. That is subdiaphragmatic air, which would therefore be consistent with pneumoperitoneum or subphrenic gas. That can happen because of a perforated intra-abdominal viscus. So there's a perforation that's happened somewhere, or some air that's been introduced into the body somehow from somewhere else. Now, I do have a case which I will be going through later where you've actually got something called a continuous diaphragm sign, where you've got air sitting.
Imran, sorry to interrupt you, but someone is raising their hand, and I think they would like to talk. Is that okay? Yeah. So I'm gonna allow the person to talk now.
Sure.
If they can. Have to unmute yourself to talk. Or maybe it was just by mistake by raising the hand.
Okay, sure, no problems.
Get on a little bit of time. So, I mean, if you just unmute yourself and try to talk, otherwise we can just continue.
Should we continue?
Yeah, I think so.
Okay, so there's a air within the underneath the hemidiaphragm, which would be suggestive of a perforated intra-abdominal viscus. So this patient will most likely need to go get a CT as quickly as possible. Right, this one is a little bit more challenging. So we have talked about perforation, but from the idea of the chest. It would be great if someone could tell me what they think this one is. but we'll go through it anyway in the meantime. So what we have is an abdominal X-ray. So generally speaking, we would say something like, we'll be looking for air-filled bowel obstruction, because if you don't have air-filled bowel obstruction, i.e. air within the bowel, then you don't have the interface between soft tissue or the tissues around the body. Exactly right. Well done. So you don't have that typical appearance of the interface. You need an interface between densities to be able to see things. So if the bowel is fluid filled and obstructed, you may not be able to see that. So that's why whenever I report these, I'd say something like there is no air-filled bowel obstruction. When you look at this particular one, you can see that the large bowel is going to be on the outside, and somewhere in the middle of all there is going to be the small bowel, just generally speaking. But when you look at this transverse colon, you can see it's very, very sort of irregularly contoured like so. It feels like, yeah, exactly like someone said, like someone stuck their thumb, pushed it in there and made a bit of an indentation. So this basically means that they've got what looks like colitis involving the transverse colon, and that can happen because of ulcerative colitis or anything. It doesn't have to be ulcerative colitis, but it could be inflammation because of infection, ischemia. There's so many reasons that someone could have inflammation in the bowel. But the important thing to understand is that this sort of irregular appearance to the bowel wall contours is not normal, and therefore this would be indicative of colitis. And colitis will therefore lead you down a different road. Obviously, if you've got someone who's got ulcerative colitis, you might want to do further imaging depending on how bad their pain is, because if someone has got ulcerative colitis, they can end up having perforations. They can end up having perforations and collections. So it's still can be quite important to get cross-sectional imaging in patients who are known to have regular episodes of colitis, especially if they come in with a significant bout of pain. Okay, so this one I think is a very, very important X-ray to look at. And I think too often people are looking for fractures and they don't really notice there's something like this. Very, very important that we look at this. And what you can actually see here is that we've got a pediatric patient. Like we said before, we've got growth plates, and you can see the growth plates are there, there, and there. And you can see that the growth plates are very well corticated as you come closer and closer to the edges. So it looks a bit more white, a bit brighter as you come to the edges, because it's kind of always been like that. But remember how I was talking about trabeculation and bone texture. So what we're going to do now is zoom in to this area over here. And you can see trabeculation, very nice straight lines all over the place, very nice straight lines all over the place. But over here, as you kind of go across, you can see that the very nice straight lines aren't so obvious now. It looks kind of cloudy, a bit murky maybe. And then when you look at the cortical edge over there compared to the cortical edge over here, this looks a bit hazy. It doesn't look quite right, okay? So you zoom in a little bit more, and you can see very well defined, nice sclerotic edge. And maybe there's actually a little bit of an extra line sitting outside the edge, right? So that's one line there, over there, but like a double edge over here. So that must mean that there is some periosteal reaction. So when you've got periosteal reaction, you've got to start thinking about there's something more going on than meets the eye. You can have periosteal reaction in someone who's got a fracture. Sometimes you've got a fracture that's all the way down here, and then you've got periosteal reaction that goes all the way up the leg because the whole body is reacting, trying to fix itself. But this happens to be in context of this very, very abnormal area of bone texture that is sitting over within this region over here. You can't 100%, you can't see a definite communication with the growth plate, but as you kind of look closer and closer, you can see this kind of irregular, hazy bone texture that kind of goes all the way down like so. In the context of knee pain in a young patient, you have to be worried that this patient's got an aggressive process. At this point, that's all you can say, aggressive process. You could try and put a differential, and one would hope that it's nothing more than just maybe osteomyelitis. Maybe there's a Brody's abscess, which is another version of osteomyelitis as it progresses further and further, i.e. infection of the bone. But you have to be careful because it could be anything. It could be Ewing sarcoma, osteosarcomas, all sorts of things. Very, very important that you appreciate the trabeculation of the bones and if there's any cortical reaction. Unfortunately, we've had a few cases where the cortical reaction at the very least has not been appreciated on the initial inspection, and we end up getting x-rays coming up further later down the line, and yeah, things have got a little bit worse, unfortunately. Okay, so this one hopefully is I
think there's a question.
Yeah, go on. Yeah, exactly, you done it. Yes, osteomyelitis. This one actually, although it's completely correct to say osteomyelitis, this patient ended up having shoulder pain as well. They had more x-rays and they had multiple areas of similar looking appearance. And that is known as, I always forget, the phrase is CRMO. And I always remember it's like chronic, or CRMO. Let me just quickly look it up for you. Chronic recurrent multifocal osteomyelitis. And it's not necessarily infection that's caused it. but you can get multiple areas and can come at different times and stuff like that. So that particular patient has very similar appearances to their shoulder, actually. Okay. Next case, shortness of breath. Hopefully everyone can see the gross abnormality. If anyone knows the sign, the golden sign, write that down in there, that'd be great. Exactly, well done. So this is a chest x-ray, and hopefully everyone can see straight away, and not necessarily malignancy all the time, but you need to rule that out, but yeah, well done. So there is this radiopaque region that is sitting over this area over here. And actually you can see that there's a very well-defined inferior border giving that letter S, right? So that's one of the big signs, golden S sign. So you can kind of think, yeah, slam dunk, I'm done. What else do I need to really know? But you can actually say there's a little bit of deviation of the trachea towards the right, but more importantly, the hilar looks raised when you compare hilar to hilar. And there's also tenting of the hemidiaphragm as well. One more sign that'd be worth looking for is where there's crowding of the ribs, where the rib distances look equal on both sides. And actually on this particular occasion, the ribs don't look crowded, but you definitely do have raising of the hemidiaphragm, raising of the hilum, and this radiodense area that is located within the right apex. That would be consistent with right upper lobe collapse, which is known as golden S sign. Very, very typical. People love saying that sign. What can it be associated with? Yes, exactly. It can be associated with malignancy, hilar lymphadenopathy. So quite important to have a look at the hilar and make sure there's no evidence of any increased density. In this particular occasion, we don't have much in the way of increased density. Actually, what was going on, there was a big lymph node sitting up there causing obstruction and the resultant collapse of the right upper lobe. Hang on, I've just lost my time, man. Let me bring that back. Are we doing okay for time? Yeah, okay, we've got a bit more time.
Yeah, we have about 15 minutes left.
Okay, you know what? I think we're going to make this last one my last one, and then we can open the floor for questions and maybe some recommendations, and just see whether people, so I can kind of think about, right, next session, what would people like to talk about, and get for me to find cases. Okay, so this one, what do we think here? So if anyone knows, please throw it in, and we can try and work through the problem. Okay, so we're having a look at this chest X-ray. We can see that it's an adult patient. Okay, hang on. Sure, yeah, we've got, so we've got an adult patient over here. We can see that there is, you may be able to see that, yeah, so someone has said that, so they've come in with chest pain. They've come with chest pain. Right, so what we can see here is that there is this area of radial opacity that is located within this region over here. Fair enough, you may think that this patient has got consolidation, right? But consolidation, you need to see where there's air bronchograms. And yeah, fair enough, you don't always see air bronchograms, which can be a reason for consolidation. But you've got to think a little bit more about what else could be going on. You could be like, okay, this could be consolidation, chest X-ray follow-up in 4 to 6 weeks and see if it's resolved. Now, let's say this doesn't resolve and it stayed the same and the patient's still coming with chest pain. One of the key findings of this one is to have a look at the ribs, like see, rib, 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 and then you've got this area over here. Can you see that? And then you've got the rib, rib there, got rib, 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 rib. Okay, so the ribs don't look quite right. The posterior aspect is completely, you just can't even see any sort of outline. And you may think to yourself, well, that's because the consolidation is covering it, but it actually isn't. Even if you've got consolidation, you should still be able to see a bit of normal cortical edges here, but there is no cortical edge here. What it turned out to be was actually a destructive chest wall lesion causing destruction of the posterior rib. So just be careful, like I know when you see any sort of shadowing, opacification is very tempting, even in chest pain, to say like, oh, well, you know what, it's consolidation. But just have a close look, have a really close look and make sure that there is no evidence of any destructive processes. There's no hilar lymphadenopathy or anything else that may suggest that this patient's got a little bit more going on than what meets the eye. So someone's saying, is it a breast lesion? Yeah, I mean, you could say, you may think that because there's a bit of asymmetry to the breasts, but actually this was 100% a posterior chest wall lesion that was causing destruction. So a very plurally based lesion that was causing destruction there. So anyway, I think that brings us to my final case. So I hope that was useful. I'm trying to make it as if we're working together. So this is how we'd go with the registrars. Registrars would actually report the cases, then we'd go through the cases together. So we don't have that, but we do have the ability to be able to go through hopefully quite a wide gamut of cases. And by doing that, we get to have a whole breadth of stuff to go over the next few months. And this is kind of, we've done an easy few cases just to kind of ease you guys selves in. Hopefully you guys will come up to the next few talks that we do together. and be able to hopefully get through some more interesting cases. And hopefully, and the other thing I'd like to say is that some of the core concepts I've introduced here will help you be able to find the more subtle findings going forwards. Okay, so hopefully that was useful. I'll pass it back to Seidel. Thank you, everyone.
Thank you so much, Dr. Lasker. I mean, if you have any final questions, please let us know if you have any questions. But I will be sending out this collection of all these cases that we have viewed today, and I will also send out a feedback survey and the recording of this webinar very shortly. And we would really appreciate if you could take some time to answer this survey so we can continue adding value based on your feedback. But to get more cases, make sure to follow Imran on Collect the Minds, and remember that you can also add these cases to your own collection. But thank you for joining us tonight, and I hope that we see you next webinar. All right. Thank you, everyone. Bye-bye.